Let's invite the panelists to come on stage. We have Captain Dr. NIRMAL KUMAR, who is the head of the department at Institute of Child Health, Egmore. He's a keen cochlear implant surgeon and pediatric airway surgeon. We have Dr. SANJAY PRABHU, senior anesthetist from Apollo Children's Hospital. Dr. SANJAY has experience working extensively overseas and in India, and his interest is in pediatric pain management. And Dr. GOWRI SHANKAR. Dr. GOWRI SHANKAR is the head of the department at Stanley Medical College, and he's a keen otologist and a skull-base surgeon.
Okay, he's not able to join because of some personal issues today. Anyway, I think Dr. Kishore Sandhu is online. A warm welcome to Dr. Kishore Sandhu. He is from Switzerland. Many of you know him. He doesn't need any introduction. So, Dr. Sandhu, able to hear us?
Yeah, hi Thiru, I can hear you, but do you want me to share my screen or I don't understand?
No, there is a small panel discussion going on. So I want you to be part of the panel for that panel discussion for a short time, and then you can continue your talk.
Right. So just to sort of tell you, because I'm in London right now.
Okay.
I will have to leave by about in the next 1 hour's time. So right now here it's 10:40.
Okay.
I will have to leave by about 11:40 or 11:45.
Okay.
Just to keep you.
We'll try to finish as early as possible, and whenever you feel you can just say bye and you can leave.
Sure.
Thank you.
First case is 1 year female child with history of noisy breathing for the past 2 days, then history of groundnut consumption on 29/8/2003 at around 8 p.m. then followed by history of vomiting of 1 episode, then history of fast breathing following vomiting. On examination, child was awake, alert, playful, chest in drawing was present. Systemic examination, on respiratory system there is bilateral V's present. Rest of the systemic examination was normal. This is the chest X-ray of the patient. Then the child was referred to pulmonology department for fiber optic bronchoscopy. So this was the fiber optic bronchoscopy done by pulmonologist, and you can able to So in that fiber optic bronchoscopy, you can able to visualize the foreign body in the trachea, in the lower part of the trachea. So it's basically a central foreign body. So this is the post-operative X-ray on the child after removing the foreign body. So my question is first about the consent. First, actually it is for rigid bronchoscopy or fiber optic bronchoscopy, the teamwork is more important, especially the surgeon, anesthetist as well as the working staff. So my first question goes for the anesthetist. So what is the counseling you will be giving to the patient's attendants, sir, regarding this one, because you will be giving anesthesia through, because both ENT surgeon as well as anesthetist are working in the same track. So your comment, sir.
Yeah, so obviously foreign body is challenging for both the specialties, being a shared airway, and we're always grateful when we have an ENT surgeon with us because they're the best in terms of airway when we panic. So regarding what to tell the parent, basically we elicit a history about the important thing is we need to ensure about the fasting time. Okay. We don't want a full stomach when we take an airway case in theatre. And second
so
is,
how long fasting time, sir? How long will be?
See, ideally 6 hours for solids, and for clear liquids like water or any clear juice, 2 hours. 2 hours. 2 hours. That's what we follow. Yeah, that's about the fasting. Second is we elicit for any history of airway reactivity. Children generally have conditions which make them more prone for airway reactivity. Typically, children with asthma, children with recent URI, which is very common in children, and passive
They'll
smokers.
go for spasm, bronchospasm,
Yeah,
or
they have
laryngospasm.
higher likelihood for having airway-related events when there was any airway instrumentation. So that's number 2. And otherwise, it is a risky procedure. So we tell the parent that it's going to be tricky, but we will take all the precautions to manage the child safely.
Okay, because since lot of litigations are going nowadays, so we should be very careful regarding the consent. Then regarding our ENT surgeon, so ENT point of view, what consent you will be getting from the patient, sir?
See, I mean, when we go in, it's always with a clinical suspicion. Often, around half the times, you don't have evidence of a foreign body on X-ray, or maybe even more than that. So maybe about 60 to 70%, if I'm right, I don't know what the number we see. At least 2/3 we don't have radiological evidence. There's no hyperinflation. There's no radiopaque foreign body. It's always with a consent. The parent should understand that this is a diagnostic cum therapeutic procedure. There's always a chance that we might not find a foreign body. There might not be a foreign body to begin with. So I think the rapport with the parent should be good. They should understand what we are doing, why we are doing, and how we are doing.
Okay.
That needs to be clearly explained, and that should be part of the consent. So a negative scopy should be included as part of consent.
Okay. Regarding positions, during the procedure, what position you want to do bronchoscope?
Rigid bronch.
Rigid bronchoscope.
Rigid bronch usually is in supine position. Start with a direct laryngoscopy. We generally don't hyperextend to do a direct laryngoscopy. With a neutral neck, go in. In small kids with a big occiput, yes, we do put a small shoulder roll. But for older kids, we generally don't put anything under. What it does is it kinds of gives you a very weird angle. All you want is you want a coaxial view from the oral cavity, the throat, the larynx and the trachea. Once you achieve that with your direct laryngoscopy, it can be a Parsons. I know few people use a nasopharyngeal airway with a CMAC or a Miller's blade and then do rigid. That is also okay.
Sniffing position, sir? Sniffing position you will try, or only in supine position only? Like
sniffing position is what's described in book, but of course a neutral, I would probably say neutral position.
Neutral
So
position. Okay.
the problem is with sniffing position is when you hyperextend, sometimes you hit the posterior wall. You don't get far down into the bronchus.
Okay.
And once you're at the carina, just turn the head to the left if you're going down the right, and turn to the other side, turn to the right to go down to the left side. Left is little more trickier to get down because of the angle. Right is pretty much easy. You can just continue down.
Because most of the time anesthetists used to put laryngoscope or CMAC laryngoscope,
yeah.
then we will pass the
Yeah.
bronchoscope easily. So only
Yeah, I was getting that. In the present day devices, we have this video laryngoscope.
CMAC.
So we have
CMAC.
we CMAC, and under vision we introduce the bronchoscope to the ENT surgeon, and then they take over from that.
So time
positioning
duration
really
also
doesn't
will
matter.
be-
Yeah, sniffing position is good, but just that it should not be exaggerated. Like normally when we say sniffing position, people really take it to the thing and hyperextend. So what I mean is whether you call it sniffing or not, there should be no hyperextension. Some extension is okay. It should not be flexion nor hyperextension. Some amount of extension is okay, but it should not be hyperextension.
Okay, fine, sir. Regarding Dr. Mark Mervin, sir, suppose if you are using fiber optic bronchoscopy for this case, so what are the advice you will be giving to the patient attender, then how will you try?
So I think again, like's been explained, it's partly diagnostic and partly therapeutic, so the family will have to understand that. Yeah, no, I think that's...
And what kind of instrument, any specific instrument you want to use for this patient, or
For this piece
simple,
of plastic, this specific
instrument,
one,
yes, sir.
I would use the crocodile forceps
Crocodile
to
forceps.
grab the lip of it and pull it out.
Any
Yeah,
post-op
through an
post-op
LMA.
care, sir? Post-op care for this kind of patient?
No, I mean if they were hemodynamically relatively stable before, you don't anticipate any problems, so they'll be able to go to the general ward.
Okay, thank you,
Yeah.
sir.
Sorry
So-
to interrupt, sir.
Yeah.
We have 3 more minutes for our
Okay,
panel.
okay. So we'll go to the second case.
Yes, you can summarize videos if you have any.
Yeah. So I will discuss about the two more cases. Next case, a 10 months old male baby with history of ingestion of plastic mobile bulb, that is toy cell phone, which is shown in the picture. Actually, this was the picture which was removed. The child developed breathing difficulty, cough and wheeze present. This is the preoperative X-ray of the patient. X-ray of chest as well as the abdomen. This is a post-op X-ray. And what is the anesthetic? I want first to ask the anesthetist whether the X-ray is useful for this kind of foreign bodies, and what point of view you will see for the X-ray, or any other investigation you want to look after.
See, generally when the history is very classical, that the child could have a foreign body, as both the speakers have already told, X-ray really doesn't matter. We just go ahead with the bronchoscopy. And even CT, some centers do, but again, we don't have time for a CT. And for children of this age, they will require sedation for CT. So you might as well go with sedation for bronchoscopy.
Any specific precaution you will take, sir, while giving anesthesia for this kind of case?
Yeah, they're very tricky.
Yes,
Small children,
So
particularly smaller children, they have very low physiological reserves, so they can desaturate very quickly. So we maintain oxygenation as much as we can. Interrupt the surgeon as much as we can to make sure that we continue to oxygenate. I know it's difficult for the surgeons, and ventilation is again going to be tricky because we cannot ventilate with a rigid bronchoscope. We ventilate with the side port attached to the circuit, still it will cause a lot of hyperventilation. So immediately after the foreign body is retrieved, we might have to intubate, ventilate the child for some time, and then only extubate.
Dr. Mark Mervyn, you will do fiber optic bronchoscopy under LA or GA for this case? Local anesthesia or general anesthesia? You will try to remove
general anesthetic with the patient deep. Otherwise, the pictures that you shown in the first case was very light still, and much too light, and there's too much movement. It would be very difficult to do anything with that.
Dr. Kamran sir, how will you approach for this case? Any specific instruments?
Instruments, this is a small baby. What was the age again? Like this, I don't think we'd be able to use a optical grasp. 10 months, yeah.
10
that's
months,
what. So we won't be able to use an optical grasping forceps. So this probably will be a non-optical forceps. So other trick what I learnt is if you use a surgical loop, even in a non-optical forceps, you get a much magnified view. So usually they have the bronchoscope length for these ages are shorter. You probably will have a 26 centimeter log bronchoscope. Normally the loops have a working length of about 30 centimeter. So you can get a bigger, better image with a small opening. Otherwise you'll be just doing this, trying to see through a narrow tunnel and get the foreign body.
Then you use the flexible one.
Yeah, absolutely. You can use the flexible.
Okay, we'll go for third case, sir. 1-year-old male child with history of ingestion of custard apple with seed followed by choking, coughing and fast breathing. On examination, child was awake. There was chest indrawing was present. On respiratory system, left side wheeze was present. This is a preoperative X-ray of the patient. This is a fiber optic bronchoscopy done in our institute. You can able to see the custard apple seed which was projecting upwards. So this is a post-operative X-ray and the seed which was removed using rigid bronchoscopy. So my question to the anesthetist is how to tackle this kind of patient. Basically this is a migrating foreign body. Actually it was in the left side, but when I put a rigid bronchoscope, it was in the right side. So it was migrated. So this might be there will be affection of lung on both sides. So anesthetist has to be very keen in giving anesthesia. So how will you be tackled with this patient, sir?
So generally, as we mentioned earlier, the patient has to be fully deep. Again, there is a difference of opinion whether we need to sort of paralyze the patient and take over controlled ventilation or make the patient breathing spontaneously. But I think surgeons who I worked with, they generally want the patient still without any movement, no coughing, no bucking, so the procedure is quite smooth. So make sure the patient is nicely deep, preferably paralyzed, and use some method where you could continue to oxygenate the patient while the surgeon does the bronchoscopy, either through a nasal cannula where we inflate oxygen from a cylinder, plus with the side port try and ventilate.
Okay. Dr. Mark Mervyn, any experience about your migrating foreign bodies?
Not a lot, but you'll follow it as far as it goes.
Okay. Sir, your opinion, sir?
The foreign body is migrating because the patient is coughing and bucking. So once you get to a deeper plane, it will become a non-migrating foreign body, easier to remove.
Now, I had seen most seeds are like migrating because 2 cases of supporter seat I had removed. Same thing, it was in the right side. When I went inside the bronchoscope, it was in the left side. Then anesthetist correctly told, yes sir, there was a decreased saturation on the decreased airway entry on the left side. So anesthetist and surgical team as most important in this one. So I thank you all the panelists, and once again I thanks Dr. Thiru sir for giving this opportunity. Thank you.
Thank you, Dr. Nirmal. Unfortunately, we had to rush that panel a little bit.